Sadiq, please move on.
Yeah, TD, you want to take over the next talk, please?
So I think this Dr. Ajay is going to take the next talk about the repair of bile duct injury, and we will take up the question and give our comments later. Dr. Ajay, please go ahead.
Hey, good evening, TD boss. Good evening, Dr. Kapoor sir, and good evening, Dr. Sadiq sir. And it's really a nice opportunity on a topic which I think is less of a scientific topic, more of a social and other socio-economic factors into it. I'm sorry that I did not have much time. I was attending some other course for last few days, and I saw the topic at the last moment. So I'm sorry because I could not make it as well as I expected. So I'll just share my slides.
Ajay.
Okay. Thank you, sir. As always, in almost all the conferences, it happens. The speaker before you steals away half of your topic. So this has happened. So I think Biju has taken away some part of my topic. I was asked once to talk on surgical management, laparoscopic management of acute pancreatic necrosis, and the speaker before me, who was supposed to do it on open, he had almost covered all the ports and difficulties. But I'm fortunate that this topic could not be covered completely by my colleague, who was my colleague at SGPGI, because it's on bile duct injury, who should repair and who should not. More of a social reason. I will not start with a scientific point to begin my slide. My direct question: who cooks better food for you, whom you would like to have at home? Some may say my grandmom cooks it well. My mom cooks it well. At some places, yes, father, younger brother, younger sister, 5 years of age, very unlikely. So we can see a proportionate factor that the grandmother goes at the highest level because of the experience in the food. And now you have to take the other factor into it. You have to listen to it that here you can say, I did not like the food, so I will not have. But if a surgery, you don't have a choice. Who should be asked to do a skin suturing? Since we are all surgeons over here, who should be asked to do a skin suturing at the end of the procedure? Can you ask your first MBBS student to do it? Second MBBS student? Final MBBS student? Internship? First year medicine resident? Any ophthalmology resident? A surgery new joinee? No. I think in the entire scenario, the surgery first year gets the choice because it is again the hierarchy that the seniority, the experience which contributes. Whether it is cooking, whether it is skin suturing, we are still considering a seniority and experience which is having an important role. If once you have a first year resident, will you give a stapled skin suturing to him? Ethylon, normal suturing to him? Will you give it a mattress suturing to him? And then will you give a subcuticular? Now, as you get the variations into it, you like some senior person to intrude into it. So before going on to who should repair a bile duct injury, who should be attempting a bile duct injury, who should do a lap chole? That is the first question. This is still unsolved till date. Who should be restricted to doing a lap chole? Once we have everybody doing a lap chole, definitely there's more likely injuries with the beginners. Is my slide moving? Sorry. So before doing a repair, we should know why can an injury happen? These are all important for the repair as well. Is it patient related? Is it surgeon related? Is it instrumentation related? Is it the conditions related? Now, why can an injury happen? That will determine who can repair. Is it because of shortage of your time? You are having a long list. So if you're having a long list of 10 cases, if you have a bile duct injury, definitely you are running fast, and therefore in repairing also you will run fast, and that has created more problem. Were you worried when you were coming to surgery? worry because of your senior, your boss, your fight with your wife? Is it because of lack of instrumentation? If you have a lack of instrumentation for a simple lap chole, definitely it will not suffice for your advanced procedure like hepatogastrostomy. Is it lack of assistants and the supportive staff in your OT? A routine procedure, if you don't have any senior people with you or a strong supportive system, definitely for an advanced procedure, you will not have again a supportive staff. Provided you have these all factors will work if you have a adequate training, adequate exposure, and adequate experience of doing a bile duct injury repair. This is the group of people, even if with everything being adequate, they may have not adequate results. What basics we have to understand at this point in time, that we should always remember: the best time of repair is only once and the first time repair. It's not that there is not a second chance. It can't happen that if somebody has done a inadequate procedure, it cannot be repaired now, it cannot be improved now, it cannot be corrected. We have corrected it so many times, but definitely the first time when you get a chance, that is the best chance to repair for a bile duct injury. But with every coming chance, it decreases the outcomes and increases the problems. It increases the problems for the patient. He has to live a long time for a definitive surgery to cure him. For the family who has to suffer all this way, for the primary operating surgeon who has done a bile duct injury, for the surgeon who has done a first hepaticogystomy and then having a complication, and then now the final surgeon who is trying to attempt to repair it. It creates a problem for the person who has referred the patient to you for a laparoscopic cholecystectomy. It is worrying for the repairing team and the intervention radiologist who may be required. It is worrying because if it is a complex injuries, he has to show a wide anatomy in which he may have to require a large number of PTPDs. So always it is more difficult to repair in the present setting than the past setting. The past, which is the first setting, was the best chance of repair. Some of the facts, who should do a bile duct injury, which the facts which cannot be overlooked. Most of the injuries in our country happen with a specialist general and laparoscopic surgery. Why does it do? It is not that it does not happen with an expert hand. They can happen with any expert, with anybody who is doing a lap chole. It can happen with anybody. But if you see the spectrum, if you see the numbers, if you see the volumes are with general and laparoscopic surgeon who are doing huge number of laparoscopic cholecystectomies, and then definitely a less number of trained surgeons over there can cause a large number of bile duct injuries. These injuries very often get referred from the peripheral hospitals, which are at the small cities where they lack the adequate facilities. At places with lack of availability of a very good post-operative care. I'll come to this in subsequent slides, why it is important that adequate availability of post-operative care cannot be overlooked. With non-availability of instrumentation to assist for a hepatobiliary surgeon. And at many centers, it even requires the sutures required of the PDS or 4050 PDS. I have faced all these things during my career, during last so many years, that these things are inadequately available. So these can't be overlooked, that who is doing a lap chole. The thought process, the surgeon who is doing a lap chole, we have to understand what is going on in his mind. I have shown a few slides earlier that what makes him do what can lead to a bile duct injury, whether it is stress, whether it is fight at home. You are coming to the hospital, your car gets a smaller injury or your accident, definitely that reflects on your surgery. And you think lap chole is a routine procedure, I can do it. No, definitely it affects your results. So thought process, what can a surgeon think at that point in time? First thing that comes always, I think it is not an injury. It is not a bile duct injury. It is something else which has happened. In case it is a bile duct injury, can I hide it? Can I cover it? If I can't hide it, if I can't cover it, if I think that it needs a surgery, can I repair it laparoscopically? I don't convert. If it requires conversion to open, but let's keep information to ourselves. Don't share it to anybody. I'm doing an open surgery now. I tell that I have converted a lap chole to open cholecystectomy, but I don't want to share the fact that it has undergone a bile duct injury. I just want to share that it is just a conversion. I can repair. I think I have seen, the residents usually say that I have seen a CBD exploration. So what is the difference between a other CBD surgery and this one? Some surgeon may feel that, yes, I have read about bile duct injuries. I have read about how to do it, so I can try it. I think these are the thought process which comes first time to every surgeon who has a bile duct injury. The mindset of this operating surgeon is denial is the first thing. This can't happen to me. How can, I've done so many surgeries. How can this bile duct injury happen to me? It has never happened in past, but someday it has to come. A panic. What do I tell to the family? What will the patient's family, the 10 people standing outside, what will they say? What will I tell to my colleague? My colleague Abhinav is standing there, Biju is standing there, and then they come to know that Dr. Ajay has done a bile duct injury. How will I face them? Can I cover this? I don't have to inform anybody. That is the safest thing I feel. It's a wishful thinking that perhaps nothing will happen. Let me put a drain. Everything will settle down of itself. Now let's see if a surgeon has faced this problem. What is the data on this worldwide to say? Attempted repair by the same operating surgeon who has done a lap chole in UK. I want to put a reference, but I have not put. It is up to 50% times they will attempt a repair themselves. In US, it is still more. 60 to 75% time they will try to attempt yourself. In Canada, it's again 65 to 75% times. In Italy, 95%. This is a documented data which says in Italy, 95% surgeons tend to repair themselves rather than referring. Oof. India, I don't know, it can go beyond 95. It will cross 125. I think more number of people are facing that they don't want to refer the patient. They tend to attempt to repair themselves. First repair by surgeon himself. Do we have something? This is all from Dr. Kapoor's book that he has mentioned on repair of bile duct injury, whom should be referred, that it is likely to fail because most of the surgeons who are doing a laparoscopic cholecystectomy are not trained, as what Dr. D.D. Yadav has said, in biliary injury repair, in bile duct surgeries. The success rate of a trained versus untrained surgeon. This is documented data. In a trained hands, it can still be, a success can be up to 95%, but in untrained, it is never beyond 20-25%. Most desperate attempts, the most desperate attempts usually made by a laparoscopic surgeon. He is doing a lap chole, he makes an attempt, then he will more likely to do more injuries. This is a fact which everybody universally will have to accept. He is more likely to make higher bile duct injuries, more vascular injuries, and inadvertent injuries to the other structures. I'll come to them in the coming slides now. Common wrongs. What can happen if a laparoscopic surgeon who is doing a lap chole attempts a hepatogynostomy or a repair of the bile duct injury by himself? As in my last colleague, Dr. Biju and when Dr. TD were discussing, I think they said they tend to dissect, and more dissection at the hilum, hence you tend to lose the length and convert a simple injury into a complex injury. Earlier, it was a right and left duct which were uniting. Now you attempt to go more beyond it and you get it separated in the subsequent stricture. More dissection means more vascular injury more likely. As Biju has very correctly said, don't try to identify or loop the bile duct at this point in time. You just need to repair the bile duct, and that is best done by the experts. All these things, whatever the first surgeon is trying to do, he thinks that he's trying to do it good, but unfortunately, this makes the surgery of the referring surgeon who has got the referral now more difficult. It is easier if he has done nothing. That is the best thing you can do to the patient. Best help to the patient and the surgeon who has to do a hepatogynostomy by a laparoscopic surgeon is only two things that he can do. Rather, I would say three things that he can do. One thing is leave the anatomy as intact as possible. Second, make a controlled external fistula by putting a drain as close to hilum as possible. As Biju was saying, not into the left hypochondrium, not to the spleen side where there was a collection. No, as close to the hilum as possible. Third thing, what Abhinav asked, the documentation, the record, and then Dr. Sadiq has very clearly emphasized, make a CD, make a record, and send it when you are referring. So make the life of the surgeon more easy rather than making it more complex. Give as much as data as possible. Why should it not be done at the same setting? Can I not do it? I can do it. I have done 100 cases in my life. I am a very senior surgeon. I have been seeing so many surgeries in my past. So, but it should not be done at the same setting. All the teaching has been like that. Why? I think we have to understand that for a lap chole, we just get a sonography done. But for a bile duct injury, we try to get a biliary and vascular anatomy both clear. That is very important. At the time of injury, the extent of injury might not be clear. You may do a cholangiogram, you may not have a facility of cholangiogram, you may not have been in a tune of doing a cholangiogram repeatedly. So the extent of injury is always underestimated. The vascular injury, you may assess a combined a common hepatic artery being injured, it may go unobserved. The complications, by the time when you are doing it, you are attempting to retract it, you might have done some complications which might not only in the CBD or the vascular structures, there might be an injury to the duodenum, other vascular structures, because your concentration is gone, you are under a lot of stress, you are under a lot of pressure, you are under the pressure of the patient family, you are under the pressure of your anesthetist. All these things contribute to your poor results. It is not just that you are not able to do it. An undilated ductal system, for any person who is a beginner in biliary surgery, it is always difficult to anastomose. Anatomical variations, we don't know what was the variation at this point in time. So it is very difficult to ascertain that how we can be repaired. For any major surgery, for lap chole, we don't have an extensive pre-anesthesia evaluation, a post-operative ICU in the same place, and extensive intraoperative systems like a central line or a complete monitoring of the vitals. So we may not have all these things in place, and we are trying to attempt a procedure which is much more requiring all these things. So is my OT tuned for all this? Is my hospital tuned for all this? Do I have a critical care team? Because most of the time lap chole are done in nursing home settings. So, but still we try to attempt a repair even in these settings. So for the team and the patient evaluation is not done usually. A rule: unsuccessful attempts at repair decreases the chances of repair in the same proportion. This is a simple rule of finances, mathematics, simple number rule, that more the number of unsuccessful repair, more is the chance of poor result. If you are trying to do a unwanted resection, is also a part of it. If you are trying to go into the hilum, this is also contributing to it. It is not a simple interest. It is a compound interest that the patient has to pay. It is not just 1 + 1 = 2. The more number of repairs adds to compounding of the raised to the power of. Meaning to say, if the second attempt is there, it is not 1 + 1 = 2. It is 2 raised to the power of 2, that is 4 times more complex now. If it is going to the third time, it is 2 raised to the power of 2 raised to the power of 2. So 2 to the 4, 4 to the 8, it is 8 times more difficult. So it is not only difficult 8 times in the number of in the timing of the surgery, the difficulty for the surgery, but for the family as well as for the finances. What is more harmful? Let us assess this now. Psychologically, for the surgeon, is it more harmful referring the patient to a higher trained surgeon? Is it more harmful? Most of the surgeons think at this time that this referral is very, very difficult. How will I do it? How will I tell to the other person that I have done this big problem now? Or this is more harmful. legally that you are attempting a repair by an untrained surgeon and then leading to more complications and more harm to the patient. You have to decide which is more harmful. I think it is a psychological thought process that referring is more harmful. More harmful is a legal litigation which comes in case the patient is not getting adequate treatment and the repair in the coming days. You should take cost into consideration. Always repair by the primary surgeon is more expensive. I think sometimes some of the surgeons may think that what I am saying is not correct, but there is a data onto it. A primary laparoscopic surgeon doing a hepatogastrostomy in an untrained center, subsequently referring and re-referring and requiring multiple interventions, normal cost comes to around, in dollars, it was 1.20 lakhs. Delayed repair by an experienced surgeon, that is only just 72,000. And primary repair, that is the least costly, by an biliary surgeon, that is 48,000. We have to understand that the third category may not be available always, which is least costly. But we think that the first category is the least costly, and therefore we attempt to do it, and that is a wrong way to do it. Now let's come to patient. How does he feel when a primary surgeon is repairing the procedure, is doing the injury? Lost the good and the happy days of life. These are usually young females who are undergoing a lap chole. So I think rightly said at one point in time when I was at SGPJ, Dr. Kapoor and Dr. Sadik used to say, these are the biliary cripples. These poor patients, immediate reference to an experienced center in-house, it takes 15 days for recovery. No repair done and referred takes 78 days. Primary repair of injury and then referring takes average 222 days. This is a data from West. So if a surgeon has attempted a repair of injury and then attempted by a second person who is again untrained, then referring to a specialized center, takes a longer duration for the recovery and hence more cost. If you have not done any repair but just referred, it may take a longer duration because you may take 60 days or 90 days for a waiting period and then doing a hepatogastrostomy with the formation of bile duct stricture. Yes, of course, the center which is having a continuous liver transplant program or the surgeons who are trained with doing a bile duct repair with the undilated system will have the shortest duration because the patient may have to stay for a slightly longer time. So the best circumstances are in-house experienced team being called for help. If you have a team which can provide you help, yes, that is the best circumstance. You should call for a help if you don't have it in-house, if you're not in an institution, if you're in a hospital, you have a nearby hospital where you have a surgeon who can do it, call for a help nearby. Call for help if you cannot have anybody nearby, but he can come within time to your hospital. I think that is also acceptable within a defined period of time that he can come and help you out. Or if not, then refer the patient. This help does not mean that the person will come and do the procedure in a laparoscopic theater. Understand the gravity of this situation, which I was telling in the first few slides. It is not only one person surgeon who is going to do it. He needs to have a good assistance. A normal Thomson retractor is not available at most of the places. The normal needle holders to hold these fine sutures in a long thread, a fine thread, are not available. A loop to see that undilated bile duct is not available. And at some of the places, I have seen it as an evidence, even sutures are not available. I used to carry the sutures with myself. I used to keep them with me always because in case you are called for a bile duct injury, you will require it. At that time, it was Vicryl, now it is PDS. And stapler may not be available to do a hepatogastrostomy because you need to make a rule loop. So anyway, that can be made by a hand-sewn anastomosis, but definitely if you have, it saves the time of the patient. Over the last 17 years, we have seen 63 patients with only 50% of them having a follow-up with me. Rest of the patients have been followed up only by telephonic communication by the people where I have gone and done a repair. That 2 of these patients had a poor repair. Let me tell, both of these patients, the surgeon was trying to do the repair himself. So let me again emphasize, don't attempt to do a repair yourself. It is better to call for a help and wait. Have a cold drink, have a coffee, have a tea at that time, and just wait for the doctor to come and or the trained person to come and help. Now, there is no definition about the trained surgeon. I had talked to many of my colleagues, and especially I've talked to some of the colleagues who are practicing in general surgery, not the GI surgeons or HPV surgeons. Whom do you think they should call as a trained person to do hepatogastrostomy? So, some of the things which have come arbitrarily over this discussion was anyone who has assisted more than 100 hepatogastrostomy. That is a basic requirement. This should include all variations. It should include a complex injury, post-PTBD hepatogastrostomy, undilated ductal systems, long duct strictures, and routine strictures. And who has done at least 25 simple hepatogastrostomies after this observation, which may include a hepatogastrostomy for a PD, for a colorectal cyst, a dilated CBD, or a colorectal duodenostomy. And one who has done 10 bile duct repairs in undilated system. That is a primary requirement. Without that, you should not attempt a primary repair. This is only after point number 1 that seeing 125 other simple hepatogastrostomies have been done. Please, a request to all general surgeons, don't take T-tube drainage as an experience in your bile duct injury repair. Most of the surgeons think that they have seen a T-tube drainage being done in their residency or their colleagues or their seniors, and they have done a T-tube drainage. So that is not a part of bile duct injury repair. Then whom should you refer? What is an expert center? He should have a diagnostic facility. Diagnostic facility means, I'll come to them one by one, therapeutic facilities. And so diagnostic means a good radiology. Yes, MR is a good contributory factor, but nowadays we are seeing many of MRs which will not even show a good biliary anatomy. So that is not a good MR. It is a MR available, and there's a difference between a good MR available, which can show undilated ductal system easily. A good CT scan, which has to be a triple phase CT scan, which should show a good biliary anatomy, good arterial anatomy, as well as a good venous drainage. Sometimes you may have to go for an extensive surgery, and maybe a volume assessment may be required. A good sonologist is always, most of the places it is available nowadays. Interventional radiologist is an intrinsic part of any center which is required to do a hepatogastrostomy in a bile duct injuries. A good ERC, a talented person who can do a ERC in such a system is always an asset. And a reconstructive surgeon who can do this surgery is definitely the bottom. Now, if accidentally something has happened and there's a family standing outside, you have to understand the psychology, what will hurt the family. We are thinking that we are getting hurt by our psychological factors as well as the legal aspects. These were two most important things which I felt. But what is hurting the family? If you don't take into consideration right now, you are going to do something wrong. What is hurting the family is you have not informed that complication has happened. You are trying to hide that. You are not putting the notes. And the complication is if the patient family comes to know later that there is a bile duct injury. You are hiding these truths, not taking part in their management. This is very important, which I want to emphasize. Once something has happened and you are referring to other center, I request put a good referral note, call to a surgeon. Maybe you will have to get an ambulance for this transfer. Maybe you will have to send some of your staff to that center. Please do it. That brings the confidence of the family in you. Though they may be hurting because something catastrophic has happened to them, which was not expected. So just participate in the family's problem at that point in time. Family being informed that this was a minor procedure. No, lap chole is never a minor procedure. Again, say, lap chole is a major procedure. Always take all surgeries as a major procedure and with a serious undertaking. Risk of conversion. It is not disclosed to the family. Always take a consent. Just tell them there is a less but a finite risk. There is no disclosure of the finances. The family thinks that how much will be the expenses when we go over there. Then quality of life. The female has to spend so many years of his life. The family suffering because of the bile duct injury and definitely mortality is a very disheartening thing. So with that, I would like to thank for giving me this opportunity to speak on this. I would be happy if we can discuss on some of the points of
Ajay, Dr. Abhinav has asked a question in the chat. Maybe you can take that, and then Sadiq and TD can make some
I'll
comments.
just see if I can. Can somebody read it out for me? Okay.
Yeah, I will read. He says that you quoted very high incidence of primary surgeon doing the repair or attempting the repair. Is it because of a medical legal fear of litigation and insurance?
Yeah, I think yes, Abhinav, what you are saying is correct. Most of the people have. I told you two reasons why.
Yeah, because UK's NHS system where repairs by primary surgeon just 50%, and USA where it is all paid system, and then you have insurance and litigations. So the incidence goes up to 75%, even higher in Italy.
Yes, Abhinav, what I have quoted is the data from UK and US, and they are definitely, in spite of being paid by the insurance, it is still the psychological fear in the mind. But if you see in India, it is not only the legal aspect. It is the worry that I can do it. Yeah, Dr. Kapoor wants to add something.
No. Please complete. Then I will.
So, it is a worry in the mind of the surgeon. The biggest worry which I have realized over these years is, what will I tell to the family who stand? I have gone for a repair, and I'm telling you, this is a ground reality experience. He called me from the back door. I entered the OT, did a hepatogynostomy, and then he told that I'll not tell the family anything. You may leave from the back door again. I felt this is injustice. I told him, I think don't tell that I had come, but you at least tell them that there's a problem, because if suppose this goes into stricture, what will you tell them now? This is the emergency which we are tackling. So the worry is that the doctor doesn't want to inform the family. So therefore they try to attempt it themselves. Yes, Dr. Kapoor was.
Yeah. So Ajay said that data from India. I will just read a few sentences from a publication that we did about 3 years ago. My colleagues, Dr. Supriya Sharma and Anu at SGPGI, we did this survey. So we sent a questionnaire to about 700 surgeons. About 40% responded. So total 278 people responded. As many as 86%. 86% said that they have already had a bile duct injury during lap chole, and 78% said that they have had more than one bile duct injury. So it is not that once you have one injury, you don't have another. 78% had more than one. And then there were people who had a bile duct injury, first bile duct injury, even after 10 years of practice, and even after they had done 100 lap choles. So experience and expertise is not a protection against having a bile duct injury. 80% of the respondents said that they wanted or they decided to manage the injury themselves. So it's 80% in our country. And the mortality, total 728 injuries were reported in this survey, and 37 of these patients died then and there only in the injuring surgeon's hands. Some more must have died later. So 5% mortality minimum of bile duct injury in India. So these are data from a publication which we had 3 years ago.
I agree that this 80% is amongst the people who agree that I want to participate into this.
Yes.
I'm telling you, 99% of the people who don't want to discuss this, who have had a bile duct injury. I'm recently, 2 years back, we had a person who used to refer us for a bile duct injury, and then we were conducting a survey, and we called him up twice, and then subsequently stopped referring us the patient. So it is as good as that. The people stop participating into that discussion now.
One more query, Ajay, after that.
Yeah. Okay. Yeah, Abhinav, please carry on.
So Ajay, you told that I'm sure I've seen you going for emergency calls for bile duct injury when surgeons have called you. And as you said, you must have told the operating surgeon to sit quiet and do nothing and have tea. So how many of them were sipping tea when you went there, or they were still trying to operate despite your advice not to go ahead?
Yeah, two things which I have seen is when they are doing a laparoscopic cholecystectomy, they have found the bile duct injury during laparoscopy, while the procedure is being done, and they inform me while the procedure is being done. I think they were still doing laparoscopic something or the other. I told them not to open it up. So when they were following it, they were still doing something laparoscopically. The biggest catastrophic change was those who have opened it up and then informed me. If they've opened the abdomen and informed me, by that time they will try to either puncture the bile duct or go into the hilum or something, and they will do more vascular injuries. So I think two patients of ours had again a stricture and then subsequently had a bad prognosis. But they were one of them had a complete hepatic artery being ligated during this attempt by the surgeon.
So they don't stop till the help is reaching there.
Yeah, that is a common scenario everywhere. I think Dr. Sadiq can add on to it because he gets a lot of referrals nowadays.
So, thank you, Ajay, for that interesting presentation and the issues which you raised around the surgeon and the patient. The topic was who should and who should not. So, the answer, I think, is very clear that A, inexperienced surgeon or surgeons who don't routinely do a bile duct or hepaticojejunostomy should not repair. The second thing is primary surgeon should not repair. And I'll elaborate a little bit more on that. The point which we have to understand is you've raised a lot of issues about hiding and things like that. Bile duct injury is a double hit. It hits the surgeon and hits the patient. Let's not pretend that the surgeon who's or had a bile duct injury is not affected by it. And a lot of it is a defense mechanism which they employ, though wrongly, in terms of trying to hide and cover it up. So I think the message which we should say is, if you encounter a bile duct injury, in your own interest, in a protection for litigation, the best thing is to assess, communicate with the relatives, and refer. So these three things, the primary surgeon who is not capable or does not have the wherewithal and the setup to do the repair should remember this. So communication is important, referral is important, and documentation of injury is important. And it is it's actually a protective thing that injury has occurred, which may occur due to many reasons, but the right step has been taken considering the experience available at that point of time. The second thing is, if the injury occurs in a setup which has all the facilities, should the primary surgeon repair? And I think there also, I feel that it may not be appropriate. And this would be a scenario where you will have enough help and experienced help available. And this is simply because an injury which happens, there is a lack of confidence, there is anxiety, this is fear of the repercussions of that. And therefore, it is always good to get another colleague who's equal experience, if not more, to come and do the repair at that point of time. The second point which I want to emphasize, and you said that is it a right time to repair at the first time? And I think there are caveats attached to it. There are several caveats attached to it. And we have to fulfill each and every caveat if you want to do an early repair. So the important thing is, of course, an experienced surgeon, a good setup with all the things that you said about retractors, instrumentation, sutures, etc. available. There should be no sepsis. That means it is very early referral. If it is on the table and you are there, you would be able to get the information by assessment whether there is any vascular injury or not and the level of injury. And then, as you said, you went and repaired, so you had made an assessment, and it is possible to do that. If the patient is referred early, you have time to do an evaluation. So I think before you take up this patient, you should do an MR and a CT angio so that you can get a complete assessment of the extent of injury and the vascular injury if available. If the referral is beyond a certain point, and that point is undefined, whether it is 48 hours, 72 hours, or so, for me, the cutoff would be about 48 to 72 hours when there is bile in the peritoneal cavity, which has not been drained, and the patient has been referred. Here, if I'm not contemplating a primary repair, and I may just want to do a laparoscopy, do a lavage, and put a good drain, I will not do much assessment at this point of time, except for maybe doing a CT to assess collections so that I can target them appropriately when I'm doing it. But I'm not going with a mindset of repair. But if I'm going with a mindset of repair, then I would do minimum those evaluations. So I think who should not repair is very clear. Who should repair? Maybe there may be some question marks at some point of time, but in my mind, I'm clear that the operating surgeon in any setup should not repair. He may be part of the team if they're all experienced HPB surgeons, but should not be the primary person repairing.
Points well taken, sir. I think yes, sir. Dr. Kapoor.
Yeah. So again, at the cost of repetition, 3 important prerequisites for any repair, and especially intraoperative or immediate repair or early post-operative repair, are, as has been again and again and again emphasized, a biliary surgeon, good and complete delineation of the biliary anatomy, because unless we know what the injury is, how can we repair it? And which requires, if it is intraoperative repair, it requires a very good quality cholangiogram, which we know that even in good and big institutions is a logistical problem. It is very difficult to get a good intraoperative cholangiogram. And third is, even those who believe in immediate or early repair, they say that if there is an associated vascular injury, they would not do it. So vascular evaluation also is very important. Now, intraoperative vascular evaluation means that you need an intraoperative Doppler. And as Dr. Sadiq pointed out, if you're going for an early or a late early repair after referral to a biliary center, then you need to have either a CT or an MR angiogram. And Anu is trying to connect, but Anu will give us the data that when we prospectively looked at the presence or absence of a vascular injury in a bile duct injury, a large number, I don't remember the exact number, but it was, I think, to the tune of 30, 40 or 50% of these patients had an associated vascular injury also, which happens very frequently in lap injury, because when you are mistaking the common bile duct for cystic duct, you are very likely to mistake the right hepatic artery for the cystic artery, and that would have been clipped and divided by this time. So these are the prerequisites. One more point. Most studies, of course, these studies are from the West. There is no official publication of medical legal data from India. The factors which are responsible for a case being filed and a case being successfully decided against the surgeon are obviously death of the patient as a result of bile duct injury. Second, a failure of repair. And third, and very important, repair being done in the injuring hospital by the injuring surgeon. That has emerged out as a very strong risk factor for a case being filed and a case being decided against the surgeon. I point out to the colleagues who are from India that there are CELSI guidelines for safe cholecystectomy and intraoperative or early management of bile duct injury. And they say that if you are not a biliary surgeon, you should not attempt a repair. You should refer the patient to a biliary center for endoscopic, radiological, or surgical early management. So that is a protection. As Dr. Sadiq said, this is a shield. If you do follow these guidelines in the court of law, even if a case is filed against you, you can say that I followed what the CELSI is saying, rather than do something which will be undefensible. So 3 more experts have joined on the panel. Dr. Sadaf is there. She's the chief of GI surgery at SKIMS in Srinagar. Dr. Vishal Gupta has joined on this. He, as I said earlier, is the chief of GI surgery at AIMS Bhopal. And Dr. Shahidur Rahman, who is a very senior surgeon from Bangladesh, he was trying to join on the delegates link but could not join. So I invited him to join on the Zoom link.